If you want to build a pathway or a system or develop a job or develop a post or an area that you're interested in, be a little bit proactive. If you want to see some change, you need to kind of make that change happen.
Welcome to the Dietetics Digest podcast, a podcast that helps you understand more about the different areas of dietetics and nutrition and what others are doing within them. We do this by talking to inspiring and influential individuals that are advancing practice in some way, shape, and form. Our mission is to create a resource that helps dietitians to build, grow, and share ideas with each other to help advance their practice and the practice of others. I am your host, Aaron Boyson. Welcome to the Dietetics Digest podcast. I'm pleased to welcome my guest, Graeme Syme, who actually contacted me back, I think, last year, was it? And wanted to share with everybody, the audience of the podcast, about his journey and experience in becoming an endoscopy-trained dietitian. So could you introduce yourself? So what is your job role? How did it start? What led up to this point?
Yeah, hi Aaron. Thanks for having me on your show. Yeah, so my job is I'm a GI dietitian, so I work in gastroenterology, and I've been doing that for approximately 6 years now. And my current job is a luminal post, so I work with inflammatory bowel disease predominantly. I also cover celiac disease and IBS, or it's kind of a functional GI clinic with a lot of IBS involved. Yeah, so I've been doing that for approximately 6 years. My current job is my current post is based at the Royal London Hospital, which is part of Barts, the oldest hospital in the world on its current site. Well, at least Barts Hospital would be. Yeah, so I've been here for 4 years now. The job's predominantly inflammatory bowel disease. So we run we've got a huge IBD service down here. So we've got an inflammatory bowel disease dietetic-led clinic. We've got a young adult transition clinic. So we've got patients between 16 to 24 that we would see as part of an MDT clinic, which runs every other week. We've got a celiac, so a dietetic-led celiac clinic, where we would have patients referred to the dietetic clinic from the point of diagnosis, and they would be followed up and reviewed. And then we've also got a functional GI clinic. As well as that, we've got a lot of dietetic inpatients that we would see on the wards. So the IBD caseload would also be mine.
Wow, so you've got quite a large caseload. And how long have you been doing that role for?
So I started off, my first Band 5 post was out in Essex. I loved it out there. And then I got, I think 18 months afterwards, I got a Band 6 gastro role, which is a brand new role. And it gave me the chance to kind of develop. And then I think I've been here for 4 years now. So yes, I think I've done my Band 6 job for about 2 years. So about 4 years as a Band 5, Band 6, and then Band 7 IBD, luminal disease.
What made you want to get into that area? What was that sort of, obviously there's multiple different paths you can go in within gastroenterology. Why did you pick IBD and those sort of that patient? Why did you choose to care for those patients?
Yeah, I think it was heavily influenced by my peers and my patients. So that the really nice thing about gastroenterology is diet's so important. You know, it's the GI tract. Food goes in, it's digested, you metabolize it, you absorb, and then you've got whatever waste products that you produce. With regards to inflammatory bowel disease and IBS, the patient cohort, they're young, and they're young, and you get to work with them and build a relationship with these patients over a period of time, which is great. And during one of my rotational posts as a Band 5, I was covering hepatology, and one of the gastroenterologists, it was a fairly new consultant, and as a registrar, he was heavily influenced by the dietetic department. So he had good experiences from dietitians, which then reflected on his practice, and I'd see him on the ward, he'd pull him into MDTs, he'd ask my opinion. It was a highly influential chap with regards to my career and development. Really, the people you work with, both the patients and the clinicians, really that kind of led me down this path.
And I think that's quite an important thing to remember. I think when my experience with other members of the MDT, it's been highly influenced, not with their experiences necessarily with myself, but their experience with previous dietitians, or the expectation they have from me and my knowledge set helps them to establish the need for a dietitian and helps you to ask where appropriate for your guidance and support. And I think that's really important to understand, that when we're representing dietitians, we're not just representing ourselves, we're also representing the whole profession and the future development of the profession and the improvement in patient care that dietitians can deliver. So obviously you're on this podcast because of your recent upskilling into becoming an endoscopy-trained dietitian. How did that initially start? What triggered that thought process in your mind? How did that what piqued your interest?
I guess I'm really fortunate in the sense that my post is funded by the gastroenterology service, so I predominantly work with that team. I cover all the outpatient clinics from that service. I'm not the most academic, so things research, development, management, it's not for me. So when you think of career progression, I like the clinical side. I like speaking to patients. I like working with the MDT. I come from a background in construction, so it's so to incorporate my hands into my clinical practice would be great. So Health Education England actually released some funds, so they're actually funding clinical endoscopists or the training of clinical endoscopists. There's a huge demand for uptake of diagnostic procedures. So if we think of upper GI cancer, such as stomach and esophageal cancer, it makes up a small proportion overall cancers. It's less than 2%, but the outcomes are quite poor. So the prognosis of esophageal or stomach cancers, it's not great. It's about 44% at 1 year's time. So the idea is, if we diagnose these cancers earlier, the outcomes are better. So currently there's about 20% of clinical endoscopists are performing these diagnostic procedures. So that's non-medical clinical endoscopists. So that would be nurses or allied healthcare professionals who've trained in endoscopy. And the idea for NHS, the NHS and Health Education England is to make that number about 40%. So Health Education England released some funds, and I was sort of nudged by management. This is perhaps an opportunity for you to develop your career. I kind of done a little bit of research. I spoke to the lead of gastroenterology, the endoscopy matron, my clinical lead, the dietetics head of department, and the moons aligned, which allowed me to go on. I had to apply actually, and then I was successful in the application process, and then the training started, which is a 40-week training program. And
I can imagine. Obviously, I remember when you messaged me. It was I can't remember the exact date, but it was during the pandemic or at what we now realize was the start of the pandemic. How has that affected the training process through the journey? Because obviously I remember you saying you had to take certain breaks to support your team at the hospital to provide care to maybe critically ill patients and things like that. How did that interrupt your training and things?
Yeah. I mean, I think initially seen on LinkedIn, you were, I think it was Christian Costas, you had and I thought, that's great, and during the lockdown, it was pretty much work, wasn't it? It was, you've got a family, but I was just working and coming home and sitting around the house, and I thought, this is great, for juniors, dietetic students, or anyone really, to have an insight of what's going on other parts of the country. Yeah, so we had, I applied for the clinical endoscopy course. I think the interview was February. How long was the pandemic? February 2019? When did COVID hit?
So COVID was first, I think, discovered on New Year's Eve of 2019. So it would have been 2020 if it's like right at the start of it.
The course was due to start. There was a cohort that began in April last year. And following the interview process, I wasn't. My background in endoscopy wasn't great. I had shadowed a few procedures. Most, I'd say 99.9% of the people on this course are nurses that work in endoscopy, so their background is pretty extensive. I think part of the conditional of me getting on the course was I had to spend some time in endoscopy, and then keep a journal, and then look at cases and familiarise myself with the pathways within endoscopy. I didn't get to do a lot of that because of the lockdown. Not the lockdown, because of COVID. So COVID hit, which meant a lot of these procedures were cancelled. They're aerosol generating procedures. And so as well as that, they're trying to minimise the number of people in the room. The other thing is the Royal London, we were one of the busiest COVID hit hospitals in the country. So I think we had something like 500 plus patients in our hospital. And if you know the Royal London, it's just a great big blue tower block. And then what we've got is, I think we've got 14 floors. And on top of that, there's another 2 floors. And these floors are in, it was almost like a multi-story car park. It was like, if you went up there, it would be just concrete pillars, like something you would drive your car around when you go to the shopping centre. So we had the Nightingale Centre, which is out in East London at the Excel Centre. And then, so what we've done, there was a short period of time where they were closing the Nightingale Centre and they were building this purpose-built ICU unit. So it's about 150 beds, purpose-built ICU unit, which used to be a multi-story car park. And obviously, you've got all these patients that you need staff. So a lot of the nursing staff from endoscopy, a lot of the doctors, the dietitians. We had to call in some colleagues from the community. We had to get paediatric dietitians, community dietitians. We had dietitians from neuro, from care of the elderly, from respiratory, all kind of upskilling and working within the ICU unit. So that meant a lot of my clinics were cancelled. Some of them were pushed over to telephone clinics. I was helping out, not so much in ICU, but more I was helping out in neuro and care of the elderly and respiratory and general medicine. Which meant there was a 10-week period where our endoscopy service was pretty much closed. It was closed for training anyway. So, you can imagine you're closing a service for 10 weeks. There's going to be a backlog of patients, and you've got a lot of trainees as well. So that's one of the things. If you're considering the clinical endoscopy program, you need to make sure that your endoscopy team are happy to support you. So that's one of the big challenges. You've got a lot of registrars. You've got surgical trainees, gastro trainees that need to train in endoscopy. It's part of their schooling. It's part of their training objectives. So they're a priority. Those individuals, they have to train in endoscopy. Now, if you're getting someone like me who's not a gastroenterologist or a surgeon that wants to train in endoscopy, you need to try and fit your training in with their training. So, a lot of the time you'll message a clinician, can I join your endoscopy list? I've cleared my diary on Tuesday afternoon. And you go to that list and there's 2 registrars hanging around. So you might have to split the list and share the list, which is fair. But it's definitely challenging, Aaron, particularly during the COVID time. During that 10-week period, there was no training. You're still attending the online classes. You're doing your work in the evenings.
So how did you overcome that challenge? Obviously, you had the 10-week period where you were unable to shadow any endoscopy procedures or clinics. Obviously, you still had the online training, but how did you overcome that 10-week period? Did you catch up with 10 weeks work over the next certain amount of time, or how did you tackle that challenge?
Yeah, I guess again, I've been very fortunate. The dietetics department, although we're really busy, we're kind of short-staffed. You've also got staff that are isolating themselves. So you've got staff that are isolating as well as having very few feet on the ground. But we agreed to protect my training days. So there was the virtual training, which would be your theory work. And that consisted of online teaching from John Moores University in Liverpool. So we would have online seminars, which would be every other week. As well as that, there's e-learning. So there's various modules that you have to complete online, and that SLATE, which don't ask me what it stands for, is the online module for clinical endoscopy. So you work your way through this, evenings and weekends, as well as my protected 1-day study time. With regards to the 10 weeks that was closed for endoscopy, it was closed to the practical stuff. So following, I think from February this year, I was just joining everyone's list. So I'd come in at, I'd done a couple of weekend shifts where I would join a gastroenterologist on a Saturday and would do 20 OGDs in a day. I would get on everyone's list, and the endoscopy and the gastroenterology department were great. So they prioritised my training. I had a window, so I think the 200 procedures had to be done by, I think, May this year. So between February and May, it was a case of, let's get Graeme in. So the clinical endoscopists, the consultants, they would be texting me, I've got a list this afternoon. Do you want it before I offer it to someone else? Again, I've been very fortunate to have a great team, both in the dietetics team as well as endoscopy. I'm very fortunate, Aaron.
Brilliant. That sounds fantastic. Forgive my ignorance in this regard. Do you intubate the patients if you perform the endoscopy? You said they need help with intubation. You said if you might need help with various different things, if you need help with intubation. I thought, do you intubate the patients, or is that done by?
No. So the part of the training, and this is for all trainees, whether you're like gastroenterologist or surgeon, I think. So the training is provided. It's called the JAG, which is the Joint Advisory Group for Endoscopy, and that's a governing body of endoscopy. And as part of your training is you create a portfolio, and you log all your procedures on that. So that tracking system, even if once you're qualified, you're still logging all your procedures on JAG, because you have to get your KPIs up, and you have to do so many a year once you're qualified. I think it's 100 a year to be competent in endoscopy. So for your training purposes, you've got 200 procedures that you have to do. Out of that 200 procedures, 95% of those procedures have to be done completely by the trainee. And that includes intubation. So you put the camera over the back of the tongue, down under the epiglottis, and then you'd be down into the esophagus. You have to get down into the stomach, through the pylorus, into the small intestine, into T2, so the second part of the small intestine, and then you've got a retroflexion. So there's some anatomical markers that you have to identify, and you have to tick all those boxes for 95% of your procedures.
You mentioned previously that you're on a little bit of a back foot compared to some of the other people. So you said that a lot of people on training courses were previous endoscopy nurses. They'd obviously been there for probably hundreds, if not thousands, of procedures prior to that. So they had a decent knowledge of pathways, endoscopy pathways, those sorts of things. And obviously you had to learn those and develop a further understanding of those, because those aren't really things that most dietitians would know off the top of their head, say, as well as a endoscopy nurse would. But is there any benefits that you've noticed from actually having the dietetic knowledge inform practice?
Yeah, I mean, I think a dietitian's got a lot of positive traits when it comes to working in endoscopy. I think the main one for me was formulating plans and already kind of thinking about the diagnosis beforehand. So just to kind of give you a bit of kind of insight or background, these patients, your list is already triaged. So you've perhaps got 10 patients in a morning list. From those 10 patients, you would prepare. So you would look at, why are these patients referred? Where did they come from? Was it from the GP? Was it from a consultant? Are they on a 2-week wait? Is it a straight to test? What kind of symptoms have they been having? Is there any red flags? What's their age? What medications are they on? And as a dietitian, you're already doing that. If you're in clinic or you're going to see a patient on the ward, the information gathering, that's pretty much our bread and butter. We don't do much of the hands-on stuff, but we're really good at drawing all this information and thinking about a plan, thinking about an assessment, and putting all that detail together. It's very, very similar. So you're looking at this information, you meet and greet the patient, and then you do the procedure. And afterwards, there's some questions that you can ask and you can home in on. A lot of these patients are referred for weight loss. And weight loss is thrown around quite flippantly. So you actually sit and speak to a patient and say, how much weight have you lost? Have you lost weight? Well, actually, that was intentional, that weight loss. Or there's some bereavement, or I've had some family problems and I've lost a little bit of weight. Can you quantify that weight loss? Aaron, you ask me, how many patients are screened in the endoscopy department for nutrition? Doesn't happen. So the patients, that's something that we're implementing right now. So patients come in, we don't do a must on patients that come in through endoscopy. Why don't we weigh and take a height of these patients? It's simple. It takes 2 minutes, and for a lot of patients, that could be the beginning of a journey. they see a clinician 6 months down the line, 6 weeks down the line. Oh, you were referred for a gastroscopy for weight loss. How much weight have you lost? Well, the GP didn't tell us that information. But, luckily, when you went to the diagnostic procedure for your gastroscopy, we weighed you and we've got a must. So you've only lost half a kilogram. It's insignificant. Nothing to worry about. Or you've actually lost 6 kilograms. It's a bit worrying. So yeah, I mean, there's a lot of benefits. I think everybody brings their own qualities, don't they? If you've got a nurse, the nurse has got a lot of qualities that perhaps the dietitian would overlook, and the dietitian has got a lot of kind of qualities that they would perhaps home in on. So there's definitely some pros and cons of having a dietitian on board.
Definitely, and the fact that you've brought the malnutrition screening to the endoscopy procedure is something quite, as you said, it's the start of a journey. And obviously having those points sort of laid out beforehand, and from that you could probably almost formulate a plan and initiate referrals to services that are available, and just start their journey off a little bit faster and more, having the patient being seen a lot faster. And we know that with malnutrition and with nutrition in general, the faster we do an intervention, the easier it is on the patient, and also the better the outcome. So I think that is a massive benefit to patients. It seems quite small to us, but I think overall it can have a really significant impact. And as you said about sort of monitoring weight and stuff, I can imagine that dietetic knowledge, whether the patient can remember their exact weight previously. Obviously, most dietitians have the ability to ask questions around sort of other elements of weight loss and various clothes fitting looser. And we're quite familiar with asking those sorts of questions around sort of trying to quantify weight loss, maybe not in pounds and ounces or kilograms, but actually in how much weight have they lost, whether it's significant or not significant. And when we're able to do that assessment, I think we're really quite good at it, because it's our bread and butter, should we say. It's often what our training consists of quite heavily, and also a lot of graduate roles around the world even consist of those sorts of things.
Yeah, definitely, yeah. And I think having a dietitian, there's a lot of these traits that rub off. So if you're working in an endoscopy department, I'm now what I'm doing is I'm asking the nurses, can we get this patient to jump on the scale before they leave, and hopefully these little traits will rub off, and then we'll have more people jumping on the scale before they leave. And it's like you say, a lot of this weight loss is subjective, and unless you kind of dig a little bit deeper, it's difficult to quantify whether it's significant or not. And there's simple questions that a dietitian can ask, and they can save a lot of time. They can save a lot of kind of anxiety for the patient. They can save a lot of money. It's little simple touches.
Definitely, and I think it just improves care overall, especially for these conditions like upper GI cancer, where weight losses and maintaining weight and malnutrition are extremely high risk of that. Maybe not at that point, but starting off early and making sure they're well nourished going into the various different treatments that they'll have is a massive advantage. And it probably, as they say, a stitch in time saves nine. And I think that's a phrase that can be used universally. And I think this theme with extended roles, so I've interviewed Sam Francis from Bradford Teaching Hospitals. I've interviewed Laura Clark from Rotherham Community. And this initial thing of, not all the time, but almost starting their extended scope or their advanced training on a back pedal compared to some of the other people, because they don't come from that background, and the course is particularly designed for people who have that background. So they struggle, maybe not struggle a little bit more, but they have a few more barriers to overcome. But then, as you said, they bring something to that area of work from their dietetic knowledge that wasn't there before. And I think that's such a useful perspective to have. And I think as we follow plans like the AHP Into Action about thinking about extending roles and how also other people can provide sort of nutrition support and aid to patients.
Yeah, absolutely. I mean, it's all about diversifying, isn't it? That's why we attend MDTs. That's why, dietitians are on the payroll. We're experts in nutrition. We don't know much about feet and eyes and things like that. But, you can throw your hat in the ring and you can contribute, and people learn from you. You're on an MDT talking about a complex discharge. a chap who's going home with a peg feed. The clinicians, the OTs, the physios, the doctors, the home help team, they want to know what your input is. Yeah, we've definitely got some skills, and everybody's got some skills.
I always say this to often there's a current way we have new dietitians coming into the office, and they often say similar things like, I don't know as much as other people on the ward. I don't know as much as this doctor or surgeon. I feel quite nervous in sort of expressing my opinion or various different things. And obviously it's always couched in a respectful way, understanding the roles of different team members. But I always remind them that obviously you've done so much training on nutrition and dietetics that they've not been able to do. So you can provide that assessment for the patient, that an outline of probably talking to them about the plan, the clinical risk of, say, malnutrition, and what your thoughts are on it, that they've not had that training, because obviously everyone's trained in their own area and speciality. So I think understanding that is really, really helpful in sort of, collaborating with other people. So that wherever their experience lies, they have something to give. And I think that's so important. I think even within dietetics, the different backgrounds we come into dietetics with, that should inform dietetic practice and move the profession forward. And again, it all comes back to that diversifying of the profession and helping to improve patient care overall.
Yeah. And, dietetics is a fairly young profession. I mean, what is it? Maybe 80 years old or something. And we're still finding our feet. What dietitians are doing now to what we were doing, 30 years ago. Grating cheese and making up supplement drinks with adding eggs and all sorts in the kitchen to what we're doing now. It's come on quite a bit, and it's only going to grow.
And I think we are part of that shaping, and I think we should be part of that shaping, because if we don't do it, nobody else will. Or probably I can imagine somebody who's not a trained dietitian would tell dietitians what to do, and we don't want that. We want to lead our own change and push our profession forward. So what does the future look like for yourself? Like, where do you think the role extension would work well, or how is your job going to change, or how's your working week going to look?
Yeah, so the idea is I'm back doing the role that I used to do before I was doing the endoscopy training program. So Health Education England released some funds which allowed some locum cover. So really grateful to the local team. Really grateful to my two colleagues that backfilled the clinic. And the idea now is that we're going to expand the upper GI service. So the kind of first thought would be we've got a dietetic-led celiac service. So those patients who are referred for biopsies would be put on the dietitian list, and then they would follow them up in clinic. The other thought is having the EOE service. So the dietetic providing exclusion diets, as well as some clinics, and having a kind of helpline. EOE is quite specific. There's a lot of kind of things like balloon dilatations, which have got high risk of perforation. So perhaps you're not doing the therapeutic stuff, but you could be doing some diagnostics or some tissue biopsies for patients who've got EOE, as well as following them up in clinic, giving them some dietary advice. Yeah, this has opened a lot of doors. There's no kind of clear pathway in where this is going to go. Give it 1 or 2 years time and see where we're at.
Definitely, I think it'd be interesting to see what comes out of it. And I think even if obviously Health Education funded the role because we need endoscopists, I think it's a common thing around the country that the endoscopy waiting lists are massive. And even if we can help support in that role initially, before we're able to really a pioneer an extended role, or thinking about how that would work, how that mix would marry up quite wonderfully. But I think even if you think about roles such as a dietitian placing an NG tube, they're two separate activities. The dietitian places the NG tube and then does the dietary assessment. It's not the same activity. So I don't see any difference between a dietitian performing a endoscopy on a patient and making a diagnosis of a patient and then following up and treating that patient. I mean, there's lots of benefits to that. I think the first benefit that you've mentioned is just the speed of care, the speed of input from a dietitian. And that's always something we're trying to get better, because we don't want someone to be identified of malnutrition and then be put on a waiting list, or be identified or not identified of malnutrition because it's not part of the screening procedure until later on. And then it's almost like an uphill battle for both the dietitian, but especially the patient. And obviously we know when nutrition that's an uphill battle is often more of a burden on the patient, especially things like upper GI and things like that. And if we can prevent that burden on patients, then I think that's really, really beneficial for them over. Obviously, we want to ensure that they have correct nutrition and things, but I think there's so many things you could look at, and the world is, you're a pioneer. So I think it'll be interesting to see your journey and see where it goes.
I've got a lot of people to thank for this course. It wouldn't be possible hadn't it been for Health Education England, the university, the dietetics department, the endoscopy team. The team have been absolutely fantastic. Yeah. So let's see where it goes. But there's definitely scope for dietitians to start doing more diagnostic as well as treatment and therapeutic parts of the pathway.
There's a lot of dietitians out there that want to get more hands-on, and it's always as again a lot of things like management structures and what a dietitian does, and how do we actually ring fence that time that actually prevents them from doing that. And it might be an interesting diversification of a dietitian's role to have clinics, but also have, say, endoscopy procedures that they conduct as well. What has been the most challenging thing about this whole process of actually becoming a endoscopy-trained dietitian?
The most challenging part is time management and prioritization. I'm very grateful that the dietetics department we've got here, my colleagues are absolutely fantastic. The gastro team, the endoscopy team, I wouldn't change them for the world. But at the same time, there's been a 10-week period where you couldn't train, and then we're kind of playing catch up. You've got the academic coursework that you're doing kind of evenings and weekends. Then you've got friends and relationships and things like that. We've got some locum staff to help cover clinics. But at the same time, these little clinics are my clinics. I've built those clinics over 4 years. I want to know what's going on in these clinics. And that's one of the things I would say to newly qualified dietitians is don't jump into things. Take your time, assess the ground. I think you need to be patient. Don't volunteer. It's easy, when you start a new job or you get quite enthusiastic about something and you jump in and you think, oh yeah, I can do this. My caseload's not busy right now. I can do this. I can do that. The next thing you've got journal groups and service developments, and you're doing diet sheets, and you've got your lunch and little all sorts of kind of clubs and projects. And the next minute you're swamped and you're not having much fun. So I guess prioritization and time management's been the most challenging part. But I'm very grateful that colleagues have helped me with that.
And I think with those things, it can be quite attractive as a newly qualified dietitian to jump in these projects. But I would also reaffirm that these projects can be great learning opportunities. But again, as you said, you can do too many and you can be spread too thin. So I think definitely using your one-to-ones to discuss those opportunities with your supervisor is always really, really helpful. So often, sometimes with these extended roles, people report, or people anecdotally, the fear is that people will think you're taking their job. You're encroaching on their space. It doesn't sound like that's ever been any sort of discussion that you've experienced. Has been any pushback from anyone else? Any other healthcare professionals?
No, not at all. I mean, there's a big drive. The government are paying for people to train and would I say upskill?
Or side skill? Would you say side?
Yeah, side skill. I mean, I wouldn't say endoscopists are any more skilled than a dietitian. It's a different skill. Yeah, so you're training in another area that you're bringing some assets towards. I think I've been welcomed by with open arms by the team. So we've got 5 clinical endoscopists. So that's non-medical endoscopists at our site. It's like a little family. They're absolutely wonderful. The consultants, brilliant bunch. And a lot of these consultants are referring to your clinic. They know you. They're referring to your clinic. and you can have a chat with them. You're becoming a little bit. The length in communications is shortened, considerably. So you'll be up in endoscopy, joining their list, or you'll be in the room next to them. You can have a little chat. I think it's definitely helping to network between dietetics and gastroenterology. There's definitely no hostility about pinching jobs.
No. I can imagine with this one, they're happy for the help. There's a lot of jobs to go around, it sounds like. But yeah, there's a lot of work to go around for people. So I guess they're just happy for the help and support and the enthusiasm of other healthcare professionals to take part in something that they can help support them with and include other people. But I think it's been a really interesting discussion. And I think hopefully it's sort of triggered these thoughts processes in people's mind around the role of a dietitian and how their career can change and advance and move in directions that they want it to, and that there are so many opportunities out there. But then also reaffirming there are so many opportunities out there. Don't rush into them. Take your time and ensure that it's right for you, and thinking about whether you would enjoy to do that role, and think about whether it matches your personality. As you said, you're quite hands-on, so endoscopy was something that you were really intrigued by. But again, thank you so much for your time this evening, and I hope everyone has enjoyed the podcast.
Can I just say, Aaron, although I'm at work and I'm wearing my work attire, it is almost 8:30 in the evening. So just for the listeners, we're not. If anyone's watching this on Aaron's channel, we're not skiving. We're not skiving at work. It's 8:30 in the evening.
Yes. Thank you so much for your time. I think it's going to help new dietitians, but also experienced dietitians just expand their horizons and also look out for new opportunities that really pique their fancy, I think. Thanks for joining me this week on Dietetics Digest. Make sure to visit my website at dieteticsdigest.com, where you can listen to the podcast. Or why not consider subscribing on Apple Podcasts, Stitcher Smart Radio, Spotify, or basically just ask Alexa and you'll never miss a show. And while you're at it, if you found this show valuable, you could do one of two things. Firstly, if you could leave a review on the podcast app you're listening to, maybe it be Apple Podcasts or Stitcher Smart Radio, and if you could tell a friend about the podcast, that'll be really helpful to help grow the podcast more. Thank you so much for your support, and have a lovely week, day, wherever you are.